happy to have you here, Dr. Kamal. And I know you, uh, I did see a video training, that you gave, so I'm familiar with your ability to speak on this topic eloquently.
Oh,
And I've been so interested in oral HPV for a while, so I'm really glad we're able to include this in our weekend. And tomorrow, everybody, OmniPathology will present the some details about the test itself. But Dr. Kamal was a pathologist, is a pathologist by training, UCLA Medical Center. He completed his pathology training. He did a fellowship in gastrointestinal and liver pathology at UCLA. He's board certified in anatomic pathology. He has extensive experience in managing large national pathology laboratories. He's an expert in laboratory quality, an expert in gastrointestinal pathology. He's a frequent lecturer at medical schools, medical conferences throughout the United States and internationally. And his most recent interest is HPV-related oropharyngeal cancer. And that is what he's going to focus on today. And we'll have a little bit on anal HPV as well, I believe. So thank you so much and welcome.
thank you so much, Dr. Hudson, for inviting me to participate in this CME activity. It is really a pleasure and an honor to talk to all of you. Um, Today, we're going to speak about anal, oral, oropharyngeal HPV in women, and I will try to give a perspective that is pathology-centered. I'm going to start with my disclosure. I'm affiliated, as Dr. Hudson mentioned, I'm affiliated with OmniPathology, and I will reference the oropharyngeal HPV test that we offer as one example of HPV testing. I want to speak a little bit about HPV as a virus. We'll talk about anal HPV and the takeaway, a clinical takeaway for women's health, and then we'll dive into a little bit more details in oral and oropharyngeal HPV. My second disclosure or disclaimer is that this is the first time I speak to naturopathic doctors, and I had to educate myself on the specialty, and it didn't take long before realizing that naturopathic doctors and pathologists are natural allies. There are so many similarities in between us as clinicians. Naturopathic doctors are trained to identify early patterns of dysfunction, and these patterns are identified before the disease is fully established. And the approach is always focusing on prevention, individualized care, and informed clinical judgment. On the other hand, pathology is always presented as a specialty of the final diagnosis. You see some pathology reports, they say diagnosis, and it's one line, end of story, and it looks simple and uncomplicated, which is far from that. As a pathologist, as I evaluate the tissue or as I look at a molecular pathology report, I can also identify patterns and can identify a biological and molecular and histological and cellular changes that can also be identified before a disease is established. Um, so, um, in this session, what I'm going to try to do is to focus on a continuum of biological and morphological changes that are associated with HPV. And I want to present pathology as an upstream intelligence rather than a downstream routine tool. And I really enjoyed putting this presentation together because it's a concept and an approach that I haven't done before, and it put a challenge for me to come up with a good angle to you to speak about. The pathology defines disease endpoints, and integrative care influences the trajectory, and that collaboration improves outcome, because when pathology and naturopathic medicine speak the same language, patients benefit, and prevention becomes more precise rather than a speculative process. And that's hopefully something we could come to. Now, let me tell you what pathology can and cannot tell us about HPV. Pathology can identify an established epithelial injury. We can grade dysplasia morphologically and assess malignant potential. We can demonstrate the oncogenic HPV via the identification of the high-grade lesions, or through testing for P16, which is an is a surrogate for oncogenic HPV. But we cannot determine the duration of infection. I cannot look at something and say that this is a person that had HPV infection for a period of time, or a short period, or a long period. And I cannot also predict, based on morphology or even on the molecular testing in the PCR report, whether this type of HPV is likely to clear or not, or persist. We cannot also make any assessment on the immune competence of a patient and what would have resulted in this patient getting the infection, or going through a persistent infection. And also, we can only assess the anatomic site. So if I have a biopsy from an anal HPV, that will not give me any idea about what could have happened, or what could happen, or could be happening in the oral and oropharyngeal area. So again, the key concept is that pathology detects downstream consequences, but it doesn't really inform us about the immune failure. So what is HPV? HPV is the most common sexually transmitted disease in the United States. It is estimated that 80% of women will contract some form of the disease, and during their lifetime, and that HPV significantly increases the risk of oropharyngeal, cervical, and anal cancers. There are more than 100 types of HPV. They're divided into high risk and low risk. The high risks types, by definition, are associated with high-grade dysplasia and cancer. The high-risk types include these 14 types. This list actually includes more, but the 14 are the ones that are commonly tested for in the existing assays. HPV 16 is the type that is most commonly associated with squamous cell carcinoma. And now we're going to focus on the high risk. The high risk HPV, it integrates in the host cells. That integration and that and this downstream effect of that integration is not necessarily something that happened at the time of infection. The relationship between the infection and the cancer development is not fully understood. So there is a latency that nobody knows how long it would take. Many people develop HPV. The test positive for HPV could be years after the exposure. And a lot of times the HPV positivity is triggered by an immune dysfunction that results in reduction of the immunity and the activation of the viral infection. But when it comes to the oncogenic activity of HPV, it is done through two main proteins that the virus has, which is E6 and E7. And each one of those has a function or a mechanism through which cancer develops. E6 degrades P53 tumor suppressor protein, and E7 inactivates RB tumor suppressor. And again, the persistence of the infection, not the exposure, is what drives malignancy. And I just need to drive that point, and I will talk more and more about persistence in this lecture. Why does this matter to naturopathic clinicians? Think of HPV with an understanding that it is a multi-site epithelial infection. When someone is positive for HPV, because it's sexually transmitted disease, if it's a positivity or a test on a cervical pap, it is reasonable to approach this as a potential infection or a potential positivity in other sites like anal canal and the oral and oropharyngeal canal. And this is important because extracervical HPV is underdiagnosed. And it's interesting because last month I gave a lecture, and I think it was in November. I gave a lecture and it was hosted by Beyond the Cervix. People are now, this is a really great thing. People are now interested in what HPV does beyond the cervix. So pathology identifies these late stage biological consequences, and naturopathic clinicians often see the patients before the pathology manifests, and that's really where that alliance between pathologists and naturopathic physicians is going to be fruitful in the HPV front. When someone tests positive for HPV, typically they don't have any symptoms. In fact, there are even no signs, because most of the time when cervix or anal canal is positive for HPV, there are no lesions, visible lesions. So that is a very natural thing for HPV, that you don't have symptoms, and then 90% of HPV infections resolve spontaneously. And that resolution happens typically within 2 years. But cancer is basically related to the persistence of the infection. Also, cancer caused by HPV often has no symptoms, meaning that, and if you think about your patients, if you had a patient that had cervical cancer, most likely that patient did not have, you don't even get bleeding with that, but unlike endometrial cancer, for example. So the HPV related cancer typically has no symptoms, but in the oral cavity there may be, and if you have a growing lesion in the anal canal, that also can have symptoms. But in general, the HPV related cancers are asymptomatic, and of course, oropharyngeal cancer is notorious for being a hidden cancer. Now, jumping into anal HPV, the idea that is now being promoted is that most cases are not a result of receptive anal sex. HPV infection has a field effect, and through that field effect mechanism, a patient who's positive in the cervix, cervical, vaginal, or vulvar HPV will, through auto-inoculation, have positive anal HPV. That is something that is important in the conversations with the patients, and is important for us as clinicians to understand that HPV in women can happen without receptive anal intercourse. The histology of anal HPV, and over the years, the pathology societies have come together, and this now is a product of multiple iteration of categorization for the diagnosis of HPV and HPV-related epithelial lesions. So now there are two categories. You have low-grade SIL, low-grade squamous intraepithelial lesions, and high-grade squamous intraepithelial lesions. And the key distinction between the two are closely connected to the virus itself. So when we say low-grade SIL, that means that virus is in the productive phase. It's a productive infection, meaning that the virus still replicates and behaves as a virus, and it still produces E6 and E7, but these oncoproteins are still regulated. They're still under control. But in the transforming phase with the high-grade squamous intraepithelial lesions, you lose the control. They become dysregulated, and E6 and E7 are now not regulated, and they are performing the tumor suppression. And that's when you see the loss of maturation in the epithelium, and you see the enlargement of the nuclei with the high NC ratio and the typical mitoses. So understanding the connection between the histological term of L cell and H cell and the viral, and then the equivalent viral form in productive and transforming, that is of extreme value. And then understanding, of course, that the high-grade squamous intraepithelial lesion, the H cell, they carry a true malignant potential. And then with that, we understand that anal and cervical cancer are basically two sides of one coin. There are multiple similarities between anal and cervical mucosa. The malignant transformation and the epithelial abnormalities happen in the transitional transformation zone, which is the squamocolumnar junction, which is seen in the anal canal between the rectal columnar mucosa and the anal squamous mucosa, and of course in the cervical canal between the columnar and the anal and the squamous areas. So that is one similarity. The other similarity is that there is also a parallel progression where you have HPV infection, L cell, H cell, and then carcinoma. That continuum is present in both cervical and anal canal. And in many cases, we see that the similar genotype impacts when tested at the same time, the cervical and the anal paps, when tested for HPV, they both have similar genotypes. So, for example, somebody would be positive for HPV 16 in the anal and the cervical canal, or HPV 18 in both. And that is something that we see, and it goes to the mirroring between the anal and the cervical HPV. We need to understand that a positive cervical HPV is the strongest predictor of anal HPV. As pathologists, when we review the slides, we look at epithelium, and it depends on the thickness of the involvement, and that's how we grade. So a low grade is involving the lower 1/3, and then the high grade would be 2/3 and above. There is inter-observer variability, of course, because you can see somebody looking at something and saying, well, these changes have crossed the lower 1/3 and got into more than that. So that's where the inter-observer variability, but this is also where P16 comes in as a great tool, because when you have the block positive staining with P16, that is a strong indication of, because now this is the surrogate marker for oncogenic HPV. So now you could bump the low grade to high grade based on a strong positive staining with B16. Again, this is the thickness that I described, and I'm going to show you a couple of histological images. And in the middle here, I don't know if you can see my screen, my cursor, but the middle picture is an anal pap picture, and you can see cells can be binucleated. You have two nuclei right next to each other, and then you can have some halo around the nuclei. These are called coilocytic changes, typical for low-grade lesions. The top left picture is a biopsy from anal canal, and in the top of the picture, you can see a lot of clearing in the cytoplasm, and these are basically more coilocytic HPV effect changes that you see in the epithelium. And on the right side, on the top right side, we have an image of in situ hybridization, which is a test. We have two cocktails. One is for low risk, 6 and 11, and the other one is for 16 and 18. The blue cells here are the positive cells, and this is positive for low risk HPV 6 and 11, and it's really compatible with the histological findings on the left. The concordance between HPV across sites supports the idea of the auto-inoculation from cervical, genital into the anal. The persistence of the infection, and I'll talk more about that when we talk about oropharyngeal cancer, the persistence of the infection here, it reflects a host viral imbalance, and it has to do with patient's immunity. And then the pathology, when you sample and you take pathology samples, whether it's anal or pap or anal biopsy, that can support, if we have other samples from other sites like the cervix, it would be supportive to look at both and compare both and see the findings, and it would be really intriguing to see if a low cell can be seen in the cervical canal associated with a high cell of the anal. That is something that would be supported if we do pathology. Pathology would provide a lot of data in that. Then to understand the pathology report the idea is to know that when you get a biopsy and it says negative and it says normal, that doesn't mean that it's HPV free. You want to know the HPV status, you need to test for HPV PCR. And then again, the L cell and H cell is what we mentioned about a productive and transforming infection. And then pathology reflects the consequence. What we see is the consequence of the infection, but we cannot really see the actual cause in the immune side of it, of the patient. Because the immune modulation precedes pathology, of course, but it would never be visible to us. But inflammation and persistence of the infection are linked, and that's where the adjunctive care, surveillance, follow-ups are indicated. Some words about vaccination is that vaccination in general, the way it's approved by the FDA, is indicated for individuals before they start their sexual activity. So it's indicated in young, in their teens, boys and girls. And initially it was indicated for girls only, and there was a push for it to include boys. Understanding that there is they can be effective after prior exposure. That sentence does not mean that the vaccine has any therapeutic effect. There is no evidence that HPV vaccination has a therapeutic role. But there are some studies that talked about that the vaccine can help with reinfection. And the way to think about HPV is not as a binary way of thinking that it's positive, negative, next. It needs to understand that there is a progression and there's a spectrum of the infection, and that and pathology can provide tools that support patient education. So the clinical takeaway for women's health here is that anal HPV should not be framed as a behavior-specific condition. Most cases reflect extension from genital HPV disease. Prior cervical dysplasia identifies women that who are at increased risk of anal cancer. Support the risk-based surveillance and patient education rather than stigma. We actually do see this a lot in with physicians with gay men, that a lot of times the anal cancer follow-up can be very difficult because the patients are hesitant because of the stigma. But I believe also the same stigma exists for women. I want to move to the oral and oropharyngeal cancers, and we spent a lot of our work on this subject, trying to understand how HPV transforms hidden oropharyngeal lesions. And before doing that, um, let's go through a comparison between the oral and oropharyngeal cancers. Um, the growth pattern in the oral cavity is usually exophytic, outside. It's an outward and often ulcerated lesion. But in the oropharynx, it's an endophytic, ingrown submucosal type of cancer. Uh, in the oral cavity, it's usually oral cancer is in the lips, anterior tongue, floor of the mouth. In the oropharyngeal, the oropharynx is the tonsils, base of the tongue, and soft palate. Uh, when it comes to etiology, we see a lot of oral cancer caused by tobacco because there's still people chewing tobacco. HPV is still a factor, but alcohol and chronic irritation are also other factors that contribute to oral cancer. Um, but oropharyngeal cancer is mostly driven by HPV, mainly HPV 16. And maybe 20, 25 years ago, the most common cause of oropharyngeal cancer was smoking, and that was gradually declining for HPV to take over as the main cause of oropharyngeal cancer that we see today. So you could see now that with an oral exam, you could see an early lesion or an abnormal lesion or a small lesion. However, oropharyngeal cancer usually hides beneath the normal mucosa. Why is that? The reason is the topography of the tonsils. The tonsils are not a flat surface. Tonsils are lymphoid tissue covered by squamous mucosa. They have what they call invaginations, which are, peaks and valleys and dips from the surface into the base. And through these invaginations, they call these the tonsillar crypts. Through these tonsillar crypts, the HPV virus gains access to the basal layer. And you could see in this diagram that the basal layer in the base here is where the infection starts, and that's also where cancer starts. And as we mentioned in cancer, you still have the E6 and E7 are the contributing factors to the progression to cancer. And with the persistence of the infection, you will see E6 and E7. They are promote the cell cycle progression and the epithelial differentiation and the genomic instability with the evident cancer development. And because of that, the most common presentation of oropharyngeal cancer is not going to be a mass on the tonsils. It would be a nodal met, so a positive cervical lymph node. Cancer grows and extends before the patient feels anything because it's an ingrown cancer. Visual examination usually misses the crypt-based tumors. On the histology side, the top left picture is an image of a tonsillar squamous cell carcinoma. The top left shows a surface that's fairly normal, and underneath you have the tumor. So the bottom left image has the poorly differentiated squamous cell carcinoma. The bottom right is a stain called CK56, which is a high molecular weight marker that identifies squamous cells. So that proves that this is a squamous cell lesion. It was so poorly differentiated that we needed a stain to confirm that it's squamous cells. And then, of course, that is the block strong positive staining with P16. And that tells us that this is an HPV related cancer. So if someone has a tonsillar squamous cell carcinoma, that is caused by smoking, P16 would be negative. So P16 proves that this is an HPV-related tumor. The takeaway from that comparison is that oral cancers announce themselves and oropharyngeal cancers hide. That HPV reveals what visual inspection cannot. And this is the idea, is that HPV related cancer is HPV related oropharyngeal cancer is like the neglected child of cancers. It has been rising consistently, and there are no effective screening tools. So I can make an argument that this is another difference between oral and oropharyngeal cancer, because when you go to the dentist, part of that dental periodical dental exam, whether it's cleaning or anything, is to look for oral cancer. They inspect your mouth, they inspect your tongue, but nobody inspects our oropharynx regularly. And if they did, they wouldn't find anything. So because of that, we felt that we may want to pursue a tool, one of many, to help screening for oropharyngeal cancer. Because oropharyngeal cancer is rising, and it is now the most common head and neck cancer. 67% of oropharyngeal cancers in the US are HPV related. The rates are rising consistently, about 3% per year. And the incidence is rising worldwide, but the highest burden is in North America and Europe. And this was a fascinating graph that I have seen, that today in the United States and the United Kingdom, you have more men with HPV-related throat cancer than women with cervical cancer. We have a great story to tell about our success in fighting cervical cancer. We established many, many years ago a screening protocol for cervical cancer, started with pap smears, and eventually HPV testing was included. And we come today to a point where HPV testing is approved as a primary screening tool for cervical cancer. Because of this rigorous screening program that women are going through periodically for cervical cancer, we can say that the incidence of cervical cancer is declining. And it would have been unthinkable 20 or 30 years ago to say that you have more men with HPV-related throat cancer than women with cervical cancer. The good news is that HPV-associated oropharyngeal cancer has a better prognosis, but the early detection remains as a challenge. And the reason is there are no known precursor lesions. And I'm going to spend a little time on this, being a pathologist, to challenge, not to challenge that there are no known precursor lesions. I think I underlined known here because I believe there are precursor lesions, but we don't know them, or we have not been able to look in the right place. So if you think about the major cancers that we know today: colon cancer, breast cancer, cervical cancer. Colon cancer, a screening tool is colonoscopy. And through the colonoscopy, you can identify adenomatous or serrated lesions, and these are precancerous lesions. So nobody will say that. So everybody, if they ask you, what is the precursor lesion for colon cancer, it will be the adenomatous polyps or the serrated polyps. Breast cancer, you have two tools, either mammogram or self-examination. And through mammogram, you can find small lesions, or self-examination, you can find small lumps. And when biopsied, you can find the precursor lesion, the ductal carcinoma in situ. Same thing with cervical cancer. When you do pap smears and you have abnormal cytology, H cell, L cell, or you do HPV testing and you have the cellular HPV changes, all of these should be recognized as precursor lesions. But none of that we know about oropharyngeal cancer. So the question is it possible that of all cancers, this is the only cancer that has no precursor lesions? I would say no. I think the issue is that we are not looking at the right patients. And I challenge everyone to think, if somebody could be taken seriously making an argument that there are no precursor lesion for colon cancer. And in the same time, they say, but we're not doing colonoscopies. That argument would never be made. And that's exactly what we're doing here with oropharyngeal cancer. We don't have tools to enhance patient selection. And now, as naturopathic physicians, I hope that you're seeing where I'm coming and how I'm trying to promote this proactive approach that can identify abnormalities before the disease is established. So the need is for a screening test. So let's go over what makes an ideal screening test. A screening test, by definition, needs to be a test that identifies disease in asymptomatic individuals. It needs to have high sensitivity, high specificity, needs to be simple and easy to perform. You wouldn't expect somebody to go through a procedure for a screening test, meaning that like an invasive procedure, and it needs to be cost effective and is safe and acceptable to patients. And it needs to result in improved outcomes, meaning that there is an action to be taken after you get the result of the test and you're not really lost what to do with that result. In the market today, when it comes to oral and oropharyngeal, there are many products to screen for HPV. And I took away things that are not PCR based because I didn't want to expand. There are other products that can do like liquid biopsy, can look for things, HPV related cancers, and these are expensive tests, but are not really considered in the same category. So I took oral DNA, I took FIDA lab, which is a saliva based, and I took the oropharyngeal swab test. And I'm comparing them, the type of specimen. So the first one, you do an oral rinse and gargle or saliva. The second one, you have saliva, and then the oropharyngeal swab. They all do PCR testing and they look for high risk HPV. The oral DNA also looks for low risk HPV. And then they all have limitations, of course, because there are no screening guidelines for any of the areas, whether it's oral or oropharyngeal. The oropharyngeal swab makes no claim on detecting anything in the oral cavity. It's just focused on the oropharynx, and it's site specific, and they all have ability to detect HPV. And this is like for FIDA lab in the top in the middle here, the oral rinse for oral DNA. Patient gets a kit and they drink liquid and they rinse and gargle. And the idea of rinse and gargle here is that the gargle would sample the oropharynx, and then the rinse. And then, but if you have a positive sample, you can't tell if the positive test is from the oral cavity or the oropharyngeal cavity. But it's actually a good thing that at least to know that this patient has oral or oropharyngeal HPV. Same thing with the saliva test for FIDA labs, and then the swab for the oropharyngeal HPV. And here it talks about the types of HPV it detects, and in each one of them. And then the report will give you a result on HPV 16, 18, and the other lumped in one. The thing that I wanted to share with you, and I was kind of really hesitant to do it, but I want to do it, and I want us to look at this just from the scientific side of it, where you have oropharyngeal swab data that is considered the largest series. There is nothing in the literature that talks about a swab for oropharyngeal HPV. We have over 1,000 patients. We have males and females. We have a range from 16 to 84. The positivity rate is 3.2%. The genotypes range from 16, 18, and others. And there were patients that over multiple testing times showed positivity with different HPV genotypes. We were able to see persistent infection where patients came back with multiple positive tests. And we also saw a co-infection where a patient comes back, co-infection with oropharyngeal and anal HPV, and also saw within the oropharynx somebody would be positive for HPV and chlamydia and gonorrhea. Um, and basically with the test being new, and we spent a lot of time working this test and trying to convince doctors about it. We felt that there has been objection. Anything new has to be questioned and challenged. And one of the biggest challenges, and this is something that I know that you see in your practice and day-to-day practice, is when someone says to us, well, HPV spontaneously resolves. Why do we have to test and give patients anxiety? And I basically answer this by saying that we do this to women every day. Nobody's making an argument. I mean, cervical HPV resolves spontaneously, but nobody's making an argument that we should stop testing for HPV because it causes anxiety or anything like that. We do this with the pap smears every day. And again, I mean, it is approved as a primary screening tool. Um, but the answer is, although it resolves spontaneously, it persists in a small percentage of patients. So, and the persistent infection is linked to cancer development. So how do we identify patients with persistent infection without testing? That's why we are pushing for testing. Well, testing gives us information, not that the positive patient has cancer. It tells us that a positive patient needs to be retested because a positive patient now can be one with persistent infection, which puts them at a higher risk of cancer development. And then the second question is, what do we do with the positive patients? So again, educating the patients that the positive test doesn't mean that you have cancer. It just means that we have to repeat, and that explaining that the persistence, if you have persistent infection, you're at a high risk of developing cancer, and you should be followed up by an ENT specialist. And the ENT can do active surgery. We work with a lot of ENTs, and they know what to do. Some of them are not familiar with that test at all, but an ENT doctor would tell you that we can do an active surveillance, we can scope, and then there are other tools, and it's just really maybe beyond the scope of this lecture to talk about the advanced things that could be done to help. But there are tools that can allow through ultrasound the doctors to see things deeper to the surface, like a transoral ultrasound. But on the pathology side of it, also, there may be an opportunity now to look at genetic testing that can identify gene amplification markers that are linked to squamous cell carcinoma. And that would be something to be done on the patients that have persistent positivity. And again, if a patient is persistently positive and has that genetic abnormality or the gene amplification marker, then that is all the reason in the world for us to look closer and follow up and continue to follow up this patient. So at least even if you detect the cancer, you detect it early. Okay. And then last but not least is the vaccination. We have a doctor who gives the vaccine to his adult patients when they're testing positive for oropharyngeal HPV. And again, we recognize that it has no therapeutic effect, but there was this one study that shows a potential role in decreasing the risk of reinfection and persistence. And this is the transoral ultrasound that I talked about. It's the idea of that product particularly, and it's a small study from Denmark. The idea of that is that it's a probe that has a smaller footprint, so it helps with the gag reflex that could be caused by the normal size ultrasound probe. But it's a small study, and probably this whole thing is saying that it may have a role in the office. And then the last objection is unnecessary expenses and investigations. And again, this was a study about the financial burden of oropharyngeal cancer. And in that, it says that the cost of treatment per new patient for the first 2 years is $140,000. And that doesn't account for additional costs due to loss of productivity of the patient and the family. Caregivers. The idea here is that we are not testing everybody. What we need to do is to come up with a protocol to select the patients, right? So you're testing and retesting, and that cost cannot be compared to the cost of treatment of oropharyngeal cancer. So what do we do here? You look at the general population. You test the high risk patients, so through history, and you identify the patient as at a high risk. By the way, risk factors for oropharyngeal cancer would be multiple sexual activity, multiple sexual partners, maybe a partner testing positive for genital HPV, reduced immunity, any kind of acquired immune deficiency, such as AIDS or diabetes. Smoking also has been identified as one of the risk factors for HPV-related oropharyngeal cancer because of the chemical impact of smoking on the local area and this of the oropharynx. So you take general population, you test the high-risk patients, you retest the positive patients, you refer the persistently positive patients to ENT doctors, and then you continue follow up accordingly. And I think that this would be a wise way to approach it. And this is, again, when we talk about these things, we recognize that there are no guidelines for screening for oropharyngeal cancer. But as a healthcare provider, I feel that it wouldn't be right for us to sit and wait for guidelines to descend upon us. We need to be proactive, and the approach is scientifically sound. HPV testing doesn't just assess risk, but it pulls the patient into a preventive care loop. Because once the patient knows that HPV is transmissible and it's vaccine preventable, they engage in more screening and vaccination and health education. There are studies showing that a positive HPV result have resulted in more care in behavioral modifications. But it prompts dialogue about vaccination and prevention. And the view is that mild short-term anxiety offset by lasting behavioral benefits. And the other thing is that a positive patient will not ignore signs of cancer. We have stories about patients saying that I had this lesion in my mouth and I ignored it, or the dentist said it's infection and they prescribed, and then it didn't go away, and after 2-3 months it became diagnosed as cancer. Nobody's going to ignore a lesion in a patient that has persistent HPV infection. The final message here for my colleagues on the clinical side is, I always say that let's use cervical HPV story and see how it motivates a safer behavior, strengthen preventive engagement, and understand that the biology and psychological triggers are the same between across the board for all HPV related cancers, and understanding that awareness leads to prevention. And hopefully one day they can look at oropharyngeal HPV and say that it was rising and it stopped rising when we started screening for HPV, or maybe screening for something else that is related to this cancer. In conclusion, I just wanted to emphasize that that HPV infection is a multiple mucosal site or a multi-site disease, and that the oncogenic process is pretty much the same across the board. Prior cervical HPV is a biological risk marker specifically for anal HPV. And the concept of looking at a whole mucosal surveillance. It's a field infection, and pathology detects the late disease, but pathology can give us a lot of other information. And the anal HPV mirrors cervical HPV. Oropharyngeal cancer lacks identifiable precursor lesions, but only because we're not looking at the right patients. And then testing for oral and oropharyngeal HPV is available. Thank you so much. And this is my email address. I'm happy to answer any questions or respond to any emails.
Thank you, Dr. Kamal. People are asking questions like, what are the indications for anal HPV testing? What are the indications and guidelines for oral HPV testing? And my
Mhm.
understanding that there are no published guidelines
For
yet.
oropharyngeal, there aren't,
Right.
but for anal HPV, and I'm not 100% sure if this is an established guideline, but it is now becoming a practice to screen for anal HPV when a patient tests positive for cervical HPV.
I don't think that's a conventional clinical guideline yet. There would be, and I think different strong STI organizations have forwarded some ideas
Mhm.
and but I don't think there's any actual published guidelines
Right,
yet.
right.
But one I think we always want to consider, tell me if you agree, women who are HIV positive with an abnormal with a HPV positive PAP, that's one group,
Hmm.
and maybe an immunosuppressed medication transplant patients with
Hmm.
a HPV positive cervical PAP, that would be another group.
Yes.
I think I would propose smokers with a positive cervical HPV would be
Mhm.
another group.
Yeah, I would agree with that, and I actually yeah, and I agree also that the HPV testing for patients with genital HPV, I know it's not a guideline, but
Yeah.
it is a recommended practice, knowing the fact that there is a field effect
Yes.
to the
Yes.
infection. Yeah, yeah,
And I think always sort of someone who has HPV 16 and 18 kind of are that
yeah,
keeps hanging around
yes,
that we always kind of want to think uh prevention minded with
yeah.
those folks and higher level of detection.
Yeah, and we have seen that also patients that are HIV positive, not even AIDS, they're just HIV positive. There is something that happens that their HPV infection tends to be exaggerated. Their hit is bigger. When you're HIV positive and you get HPV, it's a bigger hit. So there's always this idea, and I don't I think there were some studies about that showing how that an HIV infection, when you get HPV, it's usually a bigger hit, and maybe you're more likely to get a higher grade lesions.
Hmm.
Um, and it is also possible that this is a contributing factor through the immune impact of the virus, that this is a contributing factor to persistence.
Yes. This is related. Here's a good question that's related. Here's the question. Am I understanding you to say that HPV in one place can mean HPV in a different place
Eh,
and not necessarily at the same level of virulence? So could one have no findings cervically, but HSIL anally, and that's one question. And could you have low grade SIL cervically, anally, and have frank OPC?
Yeah, well, no, I mean, I wanted to be clear about that. What I am saying is that you need to think of HPV as a multi-site
Yes.
disease. And barring knowing the sexual practices of the patient, it is reasonable to want to screen for HPV and HPV related cancer in those other sites. But there
Yes.
isn't, I don't think, I mean, the only study that I'm aware of is that there is one that showed when HPV testing happens simultaneously in the cervix and the anal canal, that there is a correlation in the type of
Yeah.
the genotype of HPV. And
Yes.
but it doesn't. You can. The idea is to promote the thinking approach
Mm.
with the patient as a whole. That if
Yeah.
you're positive in one area, you should be screened for HPV in the other areas. Excellent.
Well, thank you for your Friday late afternoon, evening time. And
You're
thank you
welcome.
for our numerous communications back and forth.
My
And I think people are going to be very eager to in a preventive minded practice, right,
Mhm.
an orientation to add this kind of testing.